everybody, and welcome to this first in a series of webinars from Candela. Today we're going to be talking about vascular lesions. And just before I start, a little bit of housekeeping. If you do have a question, if you go to the control panel on your screen and where it says more, click on there and then you will see a box that says Q&A. So if you do have any questions as I'm going through the presentation, go into the Q&A box and ask the question then. And if we do have enough time, we will answer the questions at the end of the presentation. If we don't have enough time to do that at the end, what we will do is I will make sure that all of your questions are answered via email. But it's important not to use the chat button unless you're having technical issues, i.e. you can't see the screen or the sound or something isn't working correctly. That one's out of the way, so we will start. My name is Hamish McNair. I manage all of the clinical affairs for Candela in Europe, Middle East and Africa. And I've been with the company now for 9 years and about 16, 17 years in the laser industry. Apologies, having trouble with buttons. Okay, so during the presentation today, we're going to have a little very quick look at the definition of vascular lesions. I'm not going to go into this in huge detail, and we're specifically looking at the kind of vascular lesions we can treat with lasers or light-based technologies. Then we'll look at the treatment considerations, the modalities of the different kind of systems we can use to treat vascular lesions or vascular conditions. Then look at the Norless system in more detail, and then look at some of the clinical results that we can achieve using this system. So, vascular lesion classification, you basically, the simplest way to do this is to break it down into two different groups. First of all, we can look at the congenital group, and secondly, the acquired group. On the congenital side, Mulliken's classification, basically he puts again these into two. You can have vascular tumors. These tend to be rapid growing. They can be present at birth or very shortly after birth. And in many cases, you will see these will regress over the probably 9 months onwards from birth. You can see a regression in these conditions. And a typical example is a hemangioma, as you can see in this picture on the right-hand side. And depending on the severity and where this lesion is will determine whether or not it is treated by the physicians with, particularly if they're going to be using a laser. So in this instance, they probably would treat this little infant because, as you can see, there is potentially some infiltration into the nose, so there could be some issues with the airway, and also there could be some issues with the eyesight. So they would probably treat this sooner rather than later for those two reasons. The other area he talks about is vascular malformations, slightly different. These are basically problems with embryonic development, and these will grow very often with the child, and the progression can be quite slow. The commonest we see are capillary vascular malformations, which we also call port wine stains. But these malformations can be venous, they can be lymphatic and arterial, or they can be a mixture of all. So they can be quite complex. Acquired vascular lesions. So we'll have a look at some of these. First of all, probably one of the commonest things that you will see within a clinic will be patients coming in with facial telangiectasia. These can vary in size. Typically, you see them more on the cheeks, on the nose, and maybe on the top lip. Are the commonest areas you see these. Vascular lesions, so again, leg veins here. These can vary greatly in size. As you can see from the image here, we've got some very small vessels, which are probably less than 0.5 millimeter. And some of these vessels are probably 1 and potentially up to 1.5 millimeters in diameter. So you can have a wide variation in the size of vessels, particularly when you're looking at leg veins. A question I get asked a lot as I'm visiting different clinics is, what's the difference between rosacea and cuperose? And basically, the presentation is very, very similar, but rosacea is more of a progressive disease that manifests itself as flare-ups and can take different forms, which I'll explain in a moment. And in its early stages, it might only appear as redness in the middle of the face, particularly the nose and the cheek area. But over time, some of these dilated blood vessels appear along the more significant, along with more redness. And this is typically what some people will call cuperose. So they are very similar. They both manifest as telangiectasia or thread veins, and we treat them both in exactly the same way. So if the diagnosis isn't accurate, the treatment is actually the same for both of them. So there's different types of rosacea. So we can go from the milder form on the left-hand side, and then we can progress through more and more chronic versions of this condition. So we start generally, if somebody is, the first presentation of rosacea is normally some erythema, so some diffuse redness, and this may also be associated with small thread veins or telangiectasia. This can then, in some instances, progress where we move into a much more of an inflammatory lesion indication, where we have papules and pustules. This can then move on to over-proliferation of tissue, where we see the phymatose, or a rhinophyma is what it's more normally called. And finally, the other thing you can, in certain cases with rosacea, is you can actually get ocular involvement as well. And it's not necessarily a case of everybody will move from the left-hand side of the screen to the right-hand side of the screen. Some or all of these parts can be present in the very early stages. This is very typical rosacea patient. You can see they have this flushing, they have this diffuse redness, but in this case, without any telangiectasia or thread veins. Acne, very typical presentation of acne. And this can either be acne vulgaris or it could be acne rosacea. Again, the diagnosis is mainly from the fact that acne vulgaris, you'll see the little blackheads, and also it can be present not just on the face or the trunk, but it can be anywhere on the body. Whereas acne rosacea tends to be much more focused on the face rather than the rest of the body. Venous lakes, very common, small little vascular lesion on the lip. Apologize for the spelling here, that should read spider nevi, not nervous. Again, very common, you see them on the face, but you will also see them sometimes on the trunk. Here we have telangiectasia on the nose. These vessels can again vary greatly in size. You'll have, very often you will have a mixture of very small vessels around the nostrils, but on the bridge of the nose, very often you will see much larger vessels. So how do we treat vascular conditions? First thing we need to do is think about the electromagnetic spectrum. And from the slide here, you can see on the left-hand side, we're looking at gamma rays and X-rays. In the center, we have the ultraviolet light, we have visible light, and we have infrared light. And then moving to the right-hand side of the screen, we're moving into microwaves and also radio waves, as we can see here. So generally, the part of this spectrum that we are interested in is from around about 400 nanometers, so where we're into the visible light spectrum, to approximately 10,600 nanometers, which is in the infrared zone. And this is the area that we focus our lasers and our light-based technologies. Here's a set of different lasers that are commonly used within, certainly within aesthetics. Not all of them are used for vascular conditions, but I'll go through the vascular lasers in a moment. And generally, if we're looking at IPL systems, they will be somewhere in the region of 400 nanometers up to approximately 1200 nanometers as a broad spectrum of light that's being delivered. And as we move from a 400 nanometer up to 10,000 nanometers, you can see that the distance between the peak of these waves increases, and that's the length of that wave. So short waves, you can see the distance between the peaks is very close. As that wave becomes longer and longer, the distance increases between those waves, which is what we call long waves. One of the main principles when we're using a laser or a light-based system to treat anything is selective photothermolysis. And in essence, what this is it's looking at the controlled destruction of whatever our target chromophore or color is. And we do this by heating up that target using our light source. So the light is absorbed as heat into whatever our target is. We heat it up to a certain target temperature, and therefore we destroy it. And this is very specific to the wavelength or the wave band that we're using, the length of the pulse, so how long we're actually firing the laser or the light-based system into whatever our target might be, how much energy or fluence we're delivering, and also the pulse structure. Depending on what we're treating, we may want to, rather than deliver one continuous pulse, we may want to break that pulse into a number of sections in order to achieve higher temperatures in our target without damaging the surrounding tissues. And finally, treatment technique have a big effect on the efficacy of treatments. So before we treat, we need to consider a number of things. First of all, the color or the chromophore of what our target is, the size of the vessel, as we're looking at vascular today, and also the depth in the tissue. Is that vessel sitting in the reticular dermis, or is it sitting deeper in the tissue? And these all have an effect on deciding what wavelength you're going to use, and also the energy and the pulse duration you're going to use in order to coagulate that vessel. So the wavelength, here we have to think about our absorption curve. So various different wavelengths will absorb to a greater or lesser extent into whatever our target chromophore is. And today we're looking obviously at hemoglobin, and in this chart we're actually using oxyhemoglobin. So you can see 400 nanometers, we have a very strong peak of absorption, and that comes down till we're in the 500 range. Then it goes back up again to the late 500s, and then gradually it starts to drop off again. When we're looking at a laser to treat a vascular condition, we need to think somewhere in these in these ranges is the area that we want, or the wavelengths that we want to be using. There is another consideration you have to think about as well. As that wavelength increases, the depth of penetration of the laser also increases. So if we use, for instance, as you can see on the chart here, a frequency doubled ND-YAG or a KTP laser, which is 532 nanometers, you can see the absorption is very superficial. And as we move from pulse dye laser to Alexandrite to ND-YAGs, excuse me, you can see the depth of penetration of that light is getting deeper and deeper. And this is then also a consideration you need to make about how deep into the dermis is the vessel that you're trying to treat. And that will help you to steer towards which wavelength you need to use. The other interesting point on this diagram, if you look on the right-hand side at the erbium YAG at 2940 and also the CO2, the carbon dioxide laser at 10,600, you see these have suddenly are penetrating much more superficially into the tissue than the ND-YAG is. And the reason for this is both of these wavelengths absorb very strongly into water. Obviously, cells are comprised primarily of water, so as these two lasers are fired into the tissue, that water within the cells is absorbing all of the energy, so you don't get anywhere near the same depth of penetration that you do with the other lasers. Pulse duration and what we call thermal relaxation time. I think the simplest way to look at this is if you have small targets, so very small vessels with a small diameter, we're going to use a short pulse. As those vessels get larger and that diameter increases, we then need to start increasing the pulse duration in order to heat that larger volume of blood to a high enough temperature to actually coagulate it. So thermal relaxation time, this is denoted as the time it takes for 50% or more of the energy to be absorbed and to diffuse into the surrounding tissue. So in effect, what we're looking at here is we want 50% of that energy or heat to be dispersed into the surrounding tissue. And the length of time it takes is what we call our thermal relaxation time. The other point you have to think about is the thermal damage time. So this is actually slightly different to the TRT in the fact that this is how much time it's needed to actually heat whatever our structure is to a high enough temperature that we destroy it. And the thermal damage time is not always the same as the thermal relaxation time. In general, you may find that the TDT is significantly longer than your thermal relaxation time. I think this is a very useful and interesting slide. So what we're doing here is we've got the epidermis, which is in blue, and then our target, which is in red. So as we fire the energy, the light energy into the tissue, we will get an increase in the temperature of both the epidermis and whatever our target might be. If we're firing a chain of pulses, so you can see we have a pulse, then we have a delay, and then we have another pulse. During that delay time, the epidermis is cooling down significantly quicker than our target, because the thermal relaxation time of the epidermis is shorter than the thermal relaxation time of whatever our target might be, in this case, a vessel, a blood vessel. And when we fire the second pulse, we get an increase in the temperature of the epidermis back up to that threshold again. However, we still increase the temperature within our target, so our vessel. So we reach that threshold where we actually get destruction or coagulation of that vessel. And this is basically how a number of different lasers will be used for vascular treatments where they're not necessarily firing a single pulse. You may well find that even though you're only pressing the trigger once, the system could well be firing a multiple number of shots within what we call a pulse chain. So the mechanism of action when we're looking at treating vascular lesions, absorption of that wavelength by the blood, whether it be oxy or deoxyhemoglobin, and that blood vessel is then heated up to over 70 degrees, and this is where we get our coagulation. But we also get some of that heat being diffused into the wall of that blood vessel. And as blood vessels contain collagen, if you heat collagen, you will actually get contraction of that blood vessel. So we get a combination of coagulating the blood and actually reducing the size of that blood vessel with the collagen contraction. And if the vessels are incredibly small, they close up completely, and the collagen becomes quite sticky and it sticks together and the vessel is completely occluded. So once we have coagulated that vessel, in effect, as far as the body is concerned, it is no longer a blood vessel. And over time, that vessel will be reabsorbed and eliminated by the phagocytosis. And this, depending on the size of the vessel and where it is on the body, can take a matter of weeks, or it can even be up to a number of months before it's fully reabsorbed. Vessel diameter, this is really, I think, one of the critical parts when you're looking at treating any kind of a vascular lesion. It's understanding the size of that vessel. And it's possible to use something called a vein gauge to measure that diameter. And generally, all of the companies will supply you with a vein gauge when we sell you a vascular laser. If you lose it, which is very commonly happens, is it's just the size of a small credit card. A standard paperclip is 0.9 millimeters in diameter. So it gives you a very good visual reference if you've lost your vein gauge as to what size your vessel is. So here you can see using the vein gauge on the right-hand side and using a paperclip on the left-hand side. So either of these will give you a good indication of, certainly with the paperclip, whether your vessel is bigger or smaller than 1 millimeter, and we can be much more accurate with our vein gauge. There are lots of different lasers that can be used for vascular treatments. First one is the KTP, which I showed you in that diagram earlier on. This is one of the shortest wavelengths that is generally used in vascular treatments. And because of the fact that it's a short wavelength, it means that its depth of penetration into the tissue is quite shallow. You can treat superficial vessels very nicely with a KTP, but if the vessels are slightly deeper or slightly bigger, it becomes much more difficult, one, to get to the depth to be able to heat the vessel up, and secondly, in some cases, to be able to heat the complete vessel in order to get complete coagulation of that target. And also, this wavelength has quite a strong absorption into melanin, so you have to be careful if you're going to be treating slightly darker skin types with a 532 nanometer system. Moving up through the range, we have IPL systems, and as I showed earlier, these can really range anywhere from, in general, from 400, but when we're looking at vascular lasers, 500 nanometers up to about 1200 nanometers. We then have pulse dye lasers. Depending on the manufacturer, these range from about 577 to 600 nanometers. The V-beam, which is our pulse dye laser, very well known, world-renowned system, is a 595 nanometer wavelength. And that was determined after a great deal of studies, putting systems into different clinics and seeing which was the most efficient wavelength, and we found that 595 gave the best compromise between absorption into hemoglobin and depth of penetration. Your next option would be a long pulsed alexandrite at 755 nanometers. Now, a key issue again with alexandrite is it absorbs very strongly into melanin. So you can only use this wavelength in lighter skin types. It has a good depth of penetration, but it will absorb, if there's any pigment or a lot of pigment in the epidermis, it will absorb into that pigment before it gets down to wherever the vessel is. Next option would be a diode laser. Generally, for vascular treatments, we're looking more at the 940 or the 980 nanometers. One issue with diode lasers, it's very difficult to get very short pulse durations when using a diode laser. And obviously, as I've explained earlier, when we're treating very small vessels, we want to use short pulses, and as that vessel increases in size, so we increase the length of the pulse. And the final option would be a long pulsed Nd:YAG at 1064. This is particularly good for treating deeper vessels, particularly on the legs, or any other vessel that has much more depth to it. The absorption into melanin is not very high, so therefore it means that this is a much safer laser to use on darker skin, even up to skin type 6 if you need. Another question that gets asked a lot is, what is the difference between an IPL and a laser? Really, there's three main elements that we can look at that differentiate a laser from an IPL. So laser, obviously this is light amplification by the stimulated emission of radiation. And a laser is a single wavelength. And because it's a single wavelength, it means it's a single color or it's monochromatic. It's coherent. Because it's a single wavelength, all of those wavelengths are coming out in parallel with one another from the source, and it's collimated or parallel. And I think the easiest way to understand this is if you take a laser pointer and hold it 6 inches from the wall and press the trigger, you'll see a small dot on the wall. If you then move to 2 foot, 3 foot, 4 foot away from the wall and do the same thing, the dot remains approximately the same size. However, with intense pulse light, this isn't a single wavelength, it's a range of wavelengths. And because it's that range of wavelengths, it has a number of different colors in it, depending on what that range of wavelengths is. So we call this polychromatic because it's numerous colors. It's incoherent because each one of those colors is a different wavelength. So as you can see from the diagram, they're coming out and they're all slightly different wavelengths. And it's unfocused or divergent. And again, the way to demonstrate this is if you take a torch, shine it on the wall very close, the further away from the wall you go, the larger the area on the wall that is illuminated because you have that diverging beam. So now let's look at some of the technologies and the treatments. And as I said at the beginning of the presentation, what I really want to do today is to focus primarily on the Norless system with both the IPL handpieces and also the long pulsed Nd:YAG handpiece. So this is the Norless system. It has, and I'll explain more about this in a moment, one of the important things when you're looking at an IPL, particularly not just to treat vascular conditions, but whether you're treating pigment or anything else, is think about the wavelengths that handpiece is delivering. And on the Norless, we have what we call dual filtration, and I'll explain what that is in a moment. The second big advantage is we can deliver sub-millisecond pulses with this IPL handpiece. really important if you're trying to treat very small vessels, or depending on the condition you're treating, whether you need to get to the stage of actually producing purpura or bruising. It's almost impossible to produce purpura or bruising if you're using a long pulse duration. So having these very short sub-millisecond pulses allows us to, basically gives us a lot more treatment options and gives us a much more effective and efficient treatment. The machine is very easy to use, has built-in database. It gives you all of the treatment options depending on which handpiece you have connected. You select what your treatment is, having already selected the patient and the skin type, etc., and the machine will give you the starting parameters. It's very quiet. It can be hooked up to your Wi-Fi, so you have remote assistance. We don't need any cryogen cooling, and depending on the handpiece, we can treat all skin types. So it's a very versatile system. So we'll look into this in a bit more depth. If you look, excuse me, at the majority of IPL systems on the market, they'll, as everybody does, they will give you, you will see on the handpiece a number. Generally, it could be anything from 645 to maybe 545 or even 530. And what that number is denoting is that's where the initial wavelength of light is being emitted. So from, for instance, from 530 nanometers, so you have light from 530 nanometers. Now, what you will find with a large number of IPL systems is that will be the starting wavelength. But in actual fact, that handpiece may well be emitting light right up to 1200 nanometers. So a very broad spectrum of light. And one of the issues with that is once we get above around about 1,000, just over 1,000 nanometer wavelengths, we start to get strong absorption into water. And as I said before, obviously the cells are primarily made up of water. So what happens here is we start heating up the surrounding tissue quite rapidly. And this is why some anecdotally people will tell you that IPLs are more painful than lasers. And it's mainly to do with that absorption into the water and heating that water within the cells. However, with our system, rather than putting our second or our cutoff in that 1200 nanometer range, depending on the handpiece we're using, we're cutting off at a maximum wavelength of 950 nanometers. So this means we're only just getting into that stage of water becoming a strong absorber of the light. And the consequence of this is twofold. Firstly, we're not heating up the surrounding tissue to the same degree as you would be if you had a much broader range of light. So it's a much more comfortable treatment. And secondly, because we're being much more selective in the tissue that we are interacting with, we don't need to use the same level of fluence as you would with an IPL that has a much broader spectrum of light. We can, in some cases, be delivering as maybe even 50% less energy or less fluence, but still achieving the results because we're not wasting that energy on the higher wavelengths where we're absorbing that energy into water. 21 FDA indications for the Norlis. We're concentrating specifically today on vascular lesions, but just to give you an oversight, the IPL handpieces also have the ability to treat pigmented lesions, poikiloderma, benign epidermal pigmented lesions, and we can also use this system for permanent hair reduction. The Nd:YAG, as you would expect, primarily we're using this for vascular conditions, But we can also treat toenail fungus, we can treat warts, and a number of other conditions. So it gives you a very broad range of treatments all within one platform. And it's also possible to add on 2 non-ablative erbium handpieces, a 1550 and our new 1940. And these are both used for soft tissue and skin resurfacing procedures, but it's it's non-ablative, so the healing time is very quick. Big range of handpieces, and what I've done for the purposes of today is I've highlighted in red the vascular handpieces, which is the ones that we're really concentrating on during this presentation. So you can see from an IPL point of view, we have what we call the VL. So this is used for treating vascular lesions in up to skin type 4. And this has a range of 555 nanometers up to 950 nanometers. So the absorption starts at 555 and goes to 950. The PR handpiece, which we call a 530, the absorption for this one starts slightly lower down the range at 530. So the absorption, because that's a shorter wavelength, the absorption is going to be slightly more superficial in the tissue. And we use those characteristics to determine which one of these 2 handpieces we're going to use to treat certain vascular conditions. And the third vascular handpiece here is our long pulse Nd:YAG. Here we can treat leg veins up to skin type 6, although you don't tend to see vessels in skin type 6 as much as you would in lighter skin types. And we also use this for treating toenail fungus and also warts. So skip over that one. When we're looking at our vascular conditions, depending on the depth of that vessel, and also sometimes the color can give you another indication, because the darker the vessel, in general terms, it means the deeper in the tissue it's actually going. So if we're treating, excuse me, darker colored vessels, we would tend to use the VL handpiece. And if we're treating lighter colored pinker and redder vessels, which are more superficial, we're going to use the 530. And then when we get to the very deep vessels, so we're now looking at the very dark purple and dark blue colors, we would be using our Nd:YAG. So that gives you an indication of where you're going to use each one of those handpieces. Talked about pulse duration earlier, and here's, I think, a very nice slide that gives you an indication, excuse me, of the pulse durations you need to treat various different conditions. So you can see if we're treating these very pink, very small superficial vessels, very small target, so we need very short pulses. So here we're looking at using a pulse of 1.5 milliseconds. If we're looking at, and you'll see some images in a moment, of a patient who has diffuse redness, which could well be rosacea, then we tend to do quite short pulses, so 2.5 millisecond pulses, but we'll leave a delay of 10 milliseconds before we fire the second pulse. And this allows that cooling of the surrounding tissue before we start to heat up the vascular element in the tissue again. Port wine stains, 5.5 milliseconds or shorter. Once we start reducing the pulse duration when we're treating port wine stains, this is where we get to the situation where we are causing a laser bruise or purpura. And in many instances, the most efficient way of treating a port wine stain is actually to cause the purpura. And the purpura occurs because we are delivering reasonably high energies over a short period of time, rather than that vessel being able to absorb all of that heat and therefore coagulate. we totally disrupt the vessel because we're putting in that heat over a very, very short period of time. And therefore you get that blood diffusing into surrounding tissue, which is the bruise or the purpura that you see immediately after your fiber steps. And then as we move through the other vascular conditions, so telangiectasia, depending on the size of them, we're going anywhere from 10 up to 15 milliseconds. Angiomas that tend to be a little bit bigger or have a bigger volume of blood within them, we can use 17 or even 20 milliseconds. So you can see, depending on what it is we're treating, we're altering the pulse duration, so the length of time we're delivering the energy to suit the size of the target we're delivering it to. And here, this is just looking at it more in a graph form. So single pulse, large target. So this would be something we would use to treat a hair follicle or a large vessel, particularly probably a larger nasal vessel. If the target is small, we could either use 2 pulses as we do here, or 1 slightly longer pulse. But when we get to very small targets, here we're using a single very, very short pulse. Diffuse redness on our left-hand side, very, very small vessels generally within this. So we're going to use a short pulse. So we can do this in 2 different ways. We could deliver 2 pulses of 2.5 milliseconds with a delay between those 2 pulses, or the alternative is to use a 1.5 millisecond pulse, which generally will remove the redness much more quickly. It's more aggressive, but you get a much quicker clearance of that diffuse redness. Then we're looking at thin vessels. Here we could be using 10 milliseconds. Vessels get a little bit bigger as we're moving further right. So we're moving to 13 milliseconds. And then for the thicker vessels, we're up to 15 milliseconds. So you can see very logically, we increase that pulse duration just dependent on the size of the vessel that we're actually treating. When we're treating something like a cherry angioma, which is obviously a very small little lesion, the light guides on the handpieces are fairly large, and it would be pointless to deliver that energy over the whole area when we're only actually targeting a very small lesion such as Campbell-De Morgan or a cherry angioma. So what we generally do in this case is we would use a piece of paper and cut a template out of the paper. You need to remember that you need to apply your ultrasound gel to the paper and then place the handpiece over that angioma and fire your pulse. So the only part of the tissue that will be absorbing energy will be within that little cutout template that you've made from the piece of paper. The Nd:YAG handpiece, very nice, very comfortable handpiece to use. Generally leg veins, so bigger vessels, venous lakes. You can use it for port wine stains, but I would say you have to have a lot of experience, and it's used very specifically for certain parts of port wine stain. So it's more for the nodular elements within a port wine stain rather than the whole of the port wine stain. It adjusts the spot size electronically, and this is based on when you input the size of the vessel you're going to treat, the handpiece will automatically determine the spot size that you need. This is part of what we call its clinical intelligence. So you set the size of the vessel, the skin type of the patient that you're treating, and the machine will give you the fluence and also the pulse duration. You can alter both the fluence and the pulse duration if you're not seeing the clinical endpoint you're looking for, but it gives you a very effective starting point. It also has cooling built into it, so that we're able to cool the skin during the treatment. And we have 3 interchangeable tips. Regular one is the circular tip. Then we have a semicircular tip, and this is used particularly in those sometimes difficult to reach areas, so particularly around the sides of the nose where you have little vessels. So we still deliver the energy in the center of that circle, but we've removed half of that circle, so you're able to get much closer to those vessels that are sitting right up by the edge of the nose. And the third one, this has a sapphire crystal glass within it, so we can use this to actually apply a little bit of pressure, particularly useful when you're treating large spider nevi. So you apply pressure in the center of that spider nevi, and it reduces the flow of the blood, so you have a much more chance of getting good coagulation of that vessel. So moving into the third part of the presentation, here we're going to look at some of the clinical results. This is a port wine stain, and if my system will work, I have a little video. So this is quite superficial because you can see that we're using the PR530 handpiece. But you can see immediately after the treatment, we're getting some clearance of this port wine stain. Short pulse, 1.5 milliseconds, and a reasonable energy at just over 6 joules. Here we have another port wine stain. So this is after 3 treatments. Again, using the 530, because these vessels are quite superficial. You will find in a lot of cases, port wine stains are actually quite deep in the tissue, and then you need to look at using potentially a combination of both the 555 and the 530, which you can see in this instance here. Looking at the before picture, you can see that you've got a little bit of difference in the topography of this vessel. Some of it looks a little bit thicker than other parts, hence the reason of using a combination of the 555 and the 530. And this is after 3 treatments. I think this is a very nice image because it shows you how quickly you can get clearance of a port wine stain. So this is just over 2 weeks after a single treatment. It's a very nice clearance. The reason only a very small area has been treated is whenever you're treating port wine stains, you always have to do test patching, and then you need to wait at least 2 weeks, if not a month, to see how the clearance is before you decide if that's the fluids you're going to use to treat the rest of the lesion. Now we're moving on to treating thread veins. This is another video. Superficial vein. So again, this is the 530 handpiece, and you can see these vessels are literally disappearing immediately after the pulse. One of the things I particularly like about this handpiece is the size of that distance gauge. It means that, see how quickly we can treat an area on the face and how effectively we've removed those telangiectasia. And it's a very comfortable treatment for the patient as well. This is a slightly different handpiece, exactly the same wavelength, 530, but it's got a much smaller tip. And the reason for this one is particularly useful when you're trying to treat individual little telangiectasia. And you can see after the pulse, these vessels are disappearing. Very useful for nasal vessels, particularly the ones on the side of the nose. So if you are treating a lot of smaller vessels in kind of more individual, it might be an option to think about purchasing one of these handpieces in conjunction with the one with the larger light guide on it. Again, combination of using the 555 and the 530, because we have some very superficial vessels here and we've got some slightly deeper vessels here. And if you have both of these handpieces connected to the system, it's very quick and very easy to switch between the two during a single treatment. Two treatments again. So you can see we get significant clearance very, very quickly with this system. We don't need to do 3 or 4 or 5 sessions unless we're looking at generally at port wine stains. Nasal vessels, these are a little bit bigger, a bit deeper. You can see they're a darker color, and that darker color gives you the indication that they're sitting slightly deeper within the tissue. So we move from the 530, which is the more superficial absorption, to the 555, which goes deeper into the tissue and giving us very nice clearance. These are much smaller. You can see they're much finer. They're a lighter color, hence we're using 530 rather than the 555. Here we're treating cherry angiomas. I think this is, I mean, the results are very nice. All of those Campbell de Morgans have all disappeared. However, I would say one thing about the treatment here. If I was personally treating these, I would mask the surrounding area, and you could do that with a piece of damp gauze. So the only area that's actually getting the absorption from the handpiece is the angioma. Because you can see we've got a little bit of erythema around the area rather than just pinpointing that individual angioma. But the clearance is very nice. So venous lake, and this is treating with the 555. Venous lakes obviously are deeper into the tissue, so we need that deeper penetration of the energy. And this was literally a month after a single treatment, and it's virtually disappeared. Here's a small spider nevi, single treatment. It's very pale, it's very pink. So again, we know it's more superficial. So we're using the 530 rather than the 555. Now we look at diffuse redness. This is with the 555. You can see the color is quite dark, so we know that so the vascularity is deeper within the tissue. And it may even be a case for the next treatment, because we've now lightened that significantly. Professor Bering did this treatment in Denmark. So you may find that on the 4th treatment, he would move to the 530, because now he's got much more superficial vascularity than he had at the start. Again, quite dark, so we're using 555. This is treating slightly darker skin. This is Asian skin, so skin type 4. Very safely, very effectively. Here we have some vascular issues following radiotherapy, and it was a combination of 555 and 530, because you can see you've got bigger and smaller vessels, and they're at different depths within the tissue. But very nice clearance. Probably one more session will clear all of this issue. Now we've got some rosacea images. And you can see using slightly different energies and doing 1 or 2 passes can give us really good results. So you see here we started with quite a long pulse, so 3.5 milliseconds with a delay, and then another 3.5 millisecond pulse. and then a second pass with a 1.5 milliseconds. And very nice clearance. So combination here of the 555 and also what we call our PL 400, which is close to the infrared light spectrum. Nice clearance, 3 treatments here. Really, really good reduction in the diffuse redness, and unusually virtually no telangiectasia or little thread veins for this patient. So very short pulses between 1.5 or 1.9 milliseconds, and reasonable 7, nearly 8 joules, so reasonably high fluence, but good clearance. Again, 530 on Asian skin, so, or yes, Far Eastern Asian skin, so skin type 4. Much lighter skin here, but because you can see we have some different thickness within this rosacea, there's a combination of the 530 for the superficial and the 555 for the deeper lesions. Here we have telangiectasia rosacea on the nose with the 530 because they're quite small vessels. Acne vulgaris. And here what they've done is they've done a combination of the 530 with photodynamic therapy. So they apply the whatever the topical is they're using, and what happens is it's photosensitive, it absorbs slightly into the tissue, and therefore we get a much stronger reaction when we actually do the treatment. It's used quite a lot in clinics when treating acne. Another one here, that's after a single treatment. So you can see even after one treatment, the inflammatory response of the acne is reducing significantly. Less severe, but still very nice clearance after a single treatment with the 530. And darker skin, again, very safely treated, so skin type 4. And this is after a single treatment. We can also treat scars with the 530 handpiece. So what we're looking at here predominantly is removing those fine little telangiectasia or the vascularity within the scar. We won't make a massive difference to the look of the scar, to the texture of the scar. We may get a little improvement from some of the heat that we're delivering into the tissue, but the main purpose of this is to actually take away the redness of the scar. And then it would then be possible to use a non-ablative erbium to start to generate more collagen within the tissue to smooth out that scar tissue. Another one here, very red post healing, and 4 treatments using the 530 with we tend to use very short pulses, and in many cases we will actually cause some purpura or some bruising, which is transient. It probably lasts about a week, but once we've done the treatment, you can see that we've taken virtually all that vascularity out of the scar. Stretch marks, we can get very nice results, but the stretch marks need to have the vascular red element. If they're the silvery white stretch marks, then the IPL handpiece is not going to help, and you need to think about using excuse me, a non-ablative erbium for that, or a frax. So the last section is we're just going to look at some before and after pictures with our ND YAG. Here we have a larger venous lake that we're treating. So you saw a venous lake previously with the IPL handpiece. It was much shallower. This one is much deeper, it's bigger. hence the reason for using the YAG rather than the 530 handpiece. Vessels on the nose, these are quite large, but very nice clearance, single treatment. More vessels, again, single treatment to remove these. Very common condition and can be one of these things that people find very, very difficult to treat. But this was a single treatment with the 3mm spot size. Quite a long pulse because it's a big vessel, so 45 milliseconds. And you can see the big difference in the energies that we deliver with an Nd:YAG over the IPL system. With the IPL machines, handpieces, we were using 7, 8 joules. Here we're using 290 plus joules of fluid. Another vessel here. Here we have a spider nevi. Different people will treat these differently, excuse me. Sometimes you will use an Nd:YAG, particularly if you think that feeder vessel is quite big, and then the YAG is going to give us a better result than using the IPL handpiece. But we've got perfect clearance after a single pulse. And I would probably use that compression tip, the one that has the little sapphire window in it, to just apply a little bit of pressure to slightly occlude that vessel, reduce the flow, which helps us to get the coagulation and therefore the clearance. Leg veins, mixture of different sizes. I tend to think if you're treating leg veins and you have an Nd:YAG, then use the Nd:YAG rather than using the IPL handpiece. Unless the vessels are incredibly small, it saves you having to switch between two different handpieces to treat one patient in one session. So with your YAG, you'll be able to treat the very small and the much larger vessels with one handpiece, and just obviously changing your pulse durations and fluencies accordingly. This was 2 treatments, but as you can see, pretty much completely cleared. So that's basically the end of my presentation. So just really a quick summary. When you're thinking about treating vascular lesions, remember they present at different depths and also they're different sizes. And if you want to be in a situation where you can treat the very small and the larger vessels, whether it be on the face, on the trunk, or on the legs, then you need to think about choosing a system that is going to give you that flexibility of treating very small, superficial, and the larger, deeper vessels. And secondly, having the ability to deliver both long and short pulses, including these sub-millisecond pulses. So as I mentioned before, we can deliver very short pulses with the IPL handpiece, and we can actually, in certain circumstances, if we're trying to clear a port wine stain, for instance, we can even go down into sub-milliseconds, so less than 1 millisecond pulses, in order to clear certain things. And the Norless fits this criteria. And as I mentioned very briefly, because we're really focusing on vascular today, it does have the ability to treat numerous other non-vascular conditions. It's not a very big machine. It's incredibly quiet. It has a very nice user interface. It makes it very easy to work out what it is you're going to treat, the settings you're going to use, and actually physical treatment as well is very straightforward. So that's the end of my presentation. Thank you very much, everybody. I don't know if we have any questions.
Yes, Hamish?
Yeah.
Would you be able to see it at the top? Because
Hang on a minute. I'm just seeing if I can work them out. Hang on a minute. I'm just expanding it a bit so I can see. Let me see. So the first question I can see is regarding the Trivantage. The Trivantage is a nanosecond laser. So, and it runs at 50 nanoseconds. So the pulse is too short at 50 nanoseconds to really be effective in treating anything vascular. And secondly, as I mentioned earlier, with the 755, it has a much stronger absorption into melanin than it does into hemoglobin. And I think you would run into problems, and you're probably not going to be able to get enough fluence in order to actually have any effect, unfortunately, with your ATV. The next question are combination treatments with VL. They can be done at the same time. Just remember not to overdo the fluences, so you're not putting too much heat into the tissue. Next question, which is superior for treating cherryangiomas? It really depends on the size. If they're very small and very flat, the IPL treats them really well. If they're bigger, you know, the ones you see and they're slightly more raised and they're much darker in color, they've obviously got a bigger volume of blood within them, and I would then switch to the YAG to treat those. So would you treat the feeder working outwards or the veins towards the feeder of a spider nevi? The feeder is generally going to be in the center of a spider nevi. So I generally treat the center first. And if you get really good coagulation of that feeder vessel, you see a number of the little legs, in essence, the little spider legs, disappear. But any that are left, you can then work out. And always remember that you want to work proximally to distally. So follow the flow of the blood when you're treating vessels, particularly bigger vessels. Question about rosacea. Is it possible to do one session with 2 passes? Yes, there was one of the pictures there, and it even, just to make life even easier for you, it actually had both the settings and both the handpieces listed at the bottom of the picture. I think that's all I can see on here. Another one here, diffuse redness. I'm more of a fan of treating diffuse redness first, because once we've taken away that background color, it's much easier to then see the individual telangiectasia that you can then go along and remove. But in some cases, you will find, even though you're treating your diffuse redness, you will remove some of the very small telangiectasia at the same time. I'm not seeing any more, Sam. That's
Yes, that's it,
that's
Hamish.
it. Okay, well, thank you everybody very much for your attention, and look out for our next session, which we're doing in 2 weeks, I believe, and we'll be sending you more details of that. So thank you very much, and I think we're going to end the presentation now.
Thank you, Hamish. This is the end of the webinar.